operative step and discussion on post-op complications. I think Milind, you can start. Okay. So what are the indications for doing a total thyroidectomy?
Sir, indications for doing a total thyroidectomy, sir, would be, sir, benign and malignant. Sir, among benign indications, sir, we can have simple multinodular goiter. Sir, we can have a colloid goiter. Sir, among malignant, we can have, sir,
Another benign condition commonly.
sir, Graves' disease, sir, toxic multinodular goiter.
Yes.
Graves,
Toxic goiter.
yes, toxic goiter.
Not multinodular. Graves.
Toxic goiter, sir. And sir, among malignant conditions, sir, we can have, sir, thyroid malignancies.
Like?
So like papillary thyroid CA, medullary, anaplastic.
Anaplastic, it is difficult to carry out the surgery. Most of the anaplastics are inoperable. Okay. So if it is operable, yes. And then follicular. Okay. So you have decided to perform total thyroidectomy for a papillary carcinoma thyroid.
Yes, sir.
What are the operative steps you go through?
Sir, first of all, sir, the operation will be done under general anesthesia, sir, and the patient's position will be supine.
Dr. Maiti has joined.
Yes,
Dr.
sir.
Maiti, good morning.
Good morning. Good morning to everyone.
So
Sorry for the late.
No problem. Presenter is absent. I asked Milind is presenting now. So I asked Milind, what are the indications for total thyroidectomy? So he said it's a benign and malignant conditions, and benign multinodular goiter, colloid goiter, toxic goiter, and in the malignancy, all malignancy. So now I asked him to describe the steps. So please carry on. Dr. Maiti, you just
Dr. Saha, Dr. Saha, yes. you please interact. Just I will just we'll talk in between. Okay.
Okay. Milind, you said general anesthesia. Yes.
So the patient will be in general anesthesia, and the position of the patient will be supine. Sir, with the neck and will be extended. And sir, we place a pillow or a support between both the shoulder blades and the neck, and the head is placed on a head ring. Sir, the aseptic dressing and draping is done.
No, and one more thing is left. In the position, the head end should be up by. The head end will be up by 15 degrees.
15 degrees.
For what?
Sir, to ensure that so the proper venous drainage there, so the venous congestion is not there.
To reduce venous congestion, yes. Okay. Then.
So then the dressing and draping is done, sir. In case of a thyroidectomy procedure, sir, we do a 3-towel dressing.
Another thing, Milind, you also say that the arms of the patient will be by the side of the patient, so that the movement of the assistant and the surgeons become easy.
Okay, sir.
And one of the anesthetic machine, instead of keeping at the head end, and the access of the anesthetist or the IV channel,
yes, sir,
should be good, either by adding an additional channel to the IV channel, long channel.
Okay, sir.
Okay, continue.
Yes, sir. So then, sir, in case of a thyroidectomy, in case of the aseptic dressing and draping, sir, we go for a 3-towel draping, sir. And the neck, the lower part of the face, the neck, and the upper part of the chest is exposed. Yes, sir. So then, sir, should I continue with the incision, sir?
Any role for keeping a myostable over the chest?
Yes, sir. It helps a myostable with all the instruments over the chest will help in it'll make the procedure of the operation more ergonomic, sir. Because
prevent the instruments falling down.
Yes,
if
sir.
you keep on the instruments over the chest, it keeps on falling. So a myostable is kept over the chest, properly draped.
Okay, sir.
Okay, then.
So then we start with the incision, sir. So we use a thread to give a garrote marking. In case of a total thyroidectomy, sir, we use a thread to give a garrote marking, And so the incision is a it is made about 1.5 to 2 centimeters above the suprasternal notch through the cervical collar, sir. And it extends from the posterior border of one sternocleidomastoid to the posterior border of the other sternocleidomastoid, sir. And so this incision is this incision is deepened through the skin, the superficial fascia, and the platysma. And so the platysma is and so we can cut the platysma at a slightly higher level than the skin.
Okay.
So the
Continue.
next step is raising of the skin flaps, sir. As the upper margin for the raising of the upper flap, sir, it is up till the upper border of the thyroid cartilage, and the lower flap it is till the suprasternal notch, sir.
Fine.
At
Sir,
what plane you go? At what plane you go?
sir, below the platysma, sir, in the
Yeah. Subplatysmal
subplatysmal plane, sir.
avascular plane. Yes.
Subplatysmal plane, sir. So then, sir, we locate the two anterior thyroid veins, sir, and we make a we make an incision in the deep cervical fascia in between those two in the midline, sir.
Milind, instead of telling two thyroid, anterior thyroid vein, call the anterior jugular vein.
The anterior jugular vein, sir. Sorry, sir. Yes, sir. Thank you. Sir, thank you, sir. So anterior jugular vein, sir, we identify them. They are usually on both sides of the midline, and we make a incision in the investing layer of the deep cervical fascia in the midline. And sir, then we so then we dissect below this plane, sir, and we raise the fascia and the strap muscles from we lift them above the thyroid gland, sir. So this we can do first on one side, and we can complete the dissection on that particular side and then move to the other side. As one gland is completely mobilized, it is easier to mobilize the second gland. The one part of the one hemithyroid is completely mobilized. It is easier to mobilize the second hemithyroid.
What are the strap muscles you retract?
Sir, the strap muscles are
Two layers, superficial and deep.
so, sir, mylohyoid,
No. Myloid is higher up.
What are the infrahyoid strap muscle you tell?
sir, sternohyoid, sternothyroid, thyrohyoid, and omohyoid.
No. There are two layers. The superficial layer is sternohyoid medially and superficial omohyoid laterally. That is the superficial layer. The deeper layer is sternothyroid. Okay. So these are
Okay,
the
sir.
strap muscle need to retract from the thyroid lobe.
Okay, sir.
So you have retracted the sternothyroid,
Sternothyroid,
the
yes.
deep layer of the strap muscles, and then you're exposing the thyroid. Thyroid is covered by what?
So the pretracheal fascia, sir.
Yes, critical fascia. Yes. So now what to do?
Sir, then, sir, we go into the plane between the pretracheal fascia and the thyroid gland, sir. We have usually, sir, we can do it by finger dissection, sir. We go into that plane and we lift the pretracheal fascia above the thyroid gland.
Then what to do with the gland itself?
Uh,
The gland has to be retracted medially.
okay, sir.
The lobe
Yes.
has to be retracted medially, and you
Yes.
go to the lateral side of the lobe.
Lobe.
And now is the time to tackling the
Identify the
pedicle.
vascular structure, sir.
So what is the first structure you do?
So the first structure that we try to identify is the middle thyroid vein, sir. Sir, the middle thyroid vein, sir, it is uh,
Why is middle thyroid vein tackled first in during thyroidectomy? Middle thyroid vein is a very short, slender vein. If you start manipulating the gland,
It
this
might
vein
get
may
torn.
get torn. If
Okay,
it's
sir.
getting torn, it causes torrential bleed because a direct tributary of internal jugular vein.
Internal jugular vein, yes, sir.
So that's why first you tackle the middle thyroid vein,
Middle
which is a
thyroid
very
vein,
short, slender vein.
Steiner vein.
So
Okay, sir.
you go around, ligate and divide. Next,
The middle
what do
thyroid
you
vein. Sir?
do? Next pedicle.
So next pedicle, sir, we go for the superior thyroid pedicle, sir.
Okay. How do you do that?
So the muscles in this case, they are retracted upwards, and so the superior pole is exposed, and so they are the structures are dissected close to the lobe, sir. The upper pole of the lobe, sir. We dissect the structures close to the lobe, sir, and the artery and the vein are identified, and then they are ligated separately.
Which nerve needs to be safeguarded?
So the external laryngeal nerve, sir.
Yes. So that crosses medially
Medially, yes, sir.
from the upper pole. Close to the upper pole, the nerve goes medially
Medially,
to pierce the thyroid membrane.
yes, sir.
Okay. So you tackle the superior pedicle.
Superior pedicle, yes, sir.
Fine. Then
So then we come to the once the upper pole is mobilized, sir. Then we come to the inferior pedicle, sir. In case of the inferior pedicle, now we retract the muscles inferiorly, sir. Inferiorly and more inferiorly laterally, sir. And we expose the lower pole. And sir, we will then identify. Sir, in this case, we have to first identify the recurrent laryngeal nerve, sir. And sir,
yes.
the recurrent laryngeal nerve, sir, we can use sir two identifying markers, sir. One is that the nerve runs in the tracheoesophageal groove, and sir, secondly, sir, there is Berry's ligament, sir. Near the Berry's ligament, it can be found, sir. So, sir, through
What is
these
the
two,
relation to the Berry's ligament? What is the relation
sir,
of the nerve to the Berry's ligament?
sir, it lies just posterior to the Berry's ligament, sir.
Yes. It
Low
runs
to the
close to the
lower
Berry's
part of the
ligament.
Berry's ligament, just posterior to it, sir.
Fine. How do you tackle the inferior thyroid pedicle?
Sir, once we have identified the recurrent laryngeal nerve, very carefully, sir, then we will identify the inferior thyroid artery and vein, and we will ligate it, sir.
No. They are not together. What is the recommendation for ligating the inferior thyroid artery? Previously, it was the trunk. Now, you tie the individual branches of the inferior thyroid artery close to the gland.
Close to the gland.
Why? Why close to the gland?
Sir, to preserve the supply to the parathyroid.
Yes.
Preserve
So,
the supply to the
so you don't
parathyroid.
tie the earlier dictum was superior thyroid artery close to the gland, inferior thyroid artery away from the gland. Now,
Yes.
to preserve parathyroid function, you ligate individual branches
Okay,
of
sir.
the inferior artery close to the gland to preserve the supply to the parathyroid gland.
Parathyroid. Yes.
Where is the inferior thyroid vein?
Sir,
It does not follow the arteries. The inferior thyroid vein emerges at the lower pole of the thyroid lobe.
Okay, sir.
You are on the lateral side now.
Yes,
Then
sir.
you come to the lower pole of the thyroid lobe. There you
Okay.
find the inferior thyroid vein is emerging. So you dissect the lower pole of the thyroid lobe and ligate and divide the inferior thyroid veins.
Yes, sir.
Okay.
Yes, sir.
So you have ligated all the main vascular structures.
Yes, sir.
What you may find in the isthmus?
Sir, in the thyroid ima artery, thyroid ima artery, because ima
It is
artery.
not always present, but you
Yes, sir.
should look for any vessel coming to the isthmus of the lower pole.
Yes, sir.
So that will be arteriothyroidema. And what can project from the upper border of the isthmus, which you need to take care?
Uh,
You say levator glanduli thyroid
okay,
is
sir.
a pyramidal lobe of the thyroid.
Pyramidal. Oh, yes, sir. Yes, sir.
From the isthmus upper border, a projection can go up. So you need to see any position You have to take that down also.
Yes, sir.
And then go to the next side. Same steps.
Same step, yes.
Middle thyroid vein, superior thyroid pedicle, inferior artery branches, inferior thyroid vein.
Yes, sir.
So once you have done this, is thyroid free to take out?
No, sir. We still have to, sir, we have to mobilize the isthmus also, sir.
Isthmus is mobilized from?
Sir, we have to from the underlying ligament, sir, from above the trachea, sir, pretracheal fascia. We have to mobilize the isthmus of it.
Okay. Is the loop free yet? No. Is the vascular supply completely taken care of?
So there are a lot of small individual branches, sir, that
From?
directly, sir.
From tracheal and esophageal branches.
Okay, sir.
Okay, so you now lift the lobe and divide the small branches coming from the tracheal and esophagus using a bipolar cautery. And then as you come to the region of cricoid cartilage, what is tucking the thyroid?
Sir, pardon, sir. I couldn't hear.
As you come to the region of cricoid cartilage,
Yes,
what
sir.
is tucking the thyroid gland? You already
Sir,
told.
Berry's ligament, sir.
Yes.
Berry's ligament, sir.
So another area where recurrent meningeal nerve is in danger for being injured.
Yes, sir.
So once you lift the lobe near the region of cricoid cartilage, take care of the Berry's
Berry's
ligament.
ligament.
Divide the Berry's ligament, preserving the recurrent meningeal nerve.
Yes, sir.
Now the lobe is free. Okay, so once you ligate the major vessels, thyroid lobe is still stuck to the underlying trachea in the esophagus. And there are small fine branches which you need to tackle by using a bipolar cautery.
Yes, sir.
So you have taken the whole gland out. And what, apart from recurrent meningeal nerve, external nerve, what else you need to preserve during thyroidectomy? Parathyroids.
Yes, sir. Parathyroid, sir. Yes, sir.
Parathyroids. So
Parathyroid.
try to identify the parathyroids by its shining color and preserve the parathyroid along with it.
Yeah. Yes, sir.
Then
So,
what to do?
so once we've taken the specimen out, sir, we look at the bed for any bleeding, sir, and any other bleeding that is there. We have to.
Any instruction to the anesthetist? Any instruction to the anesthetist?
Yes, sir. We ask the anesthetist to do, sir, we basically have to perform a Valsalva maneuver,
Yes.
increase the pressure to see whether if any bleeding
Yeah.
that was
So
not
any
very
venous
obvious is
bleeding which
there,
has stopped
comes prominent.
on Valsalva, this can open up. So you tackle that bleeding point.
Bleeding.
What
Yes.
about drain?
Sir, we can place we should place a drain, sir, after this, sir.
Yes,
Such
most
a
of the
small.
time place a drain, but now people are saying that drain is not mandatory. If you are happy that there is no bleeding, the bed is absolutely dry, you may
Yes,
not put a drain. Okay, so drain is not mandatory, but most of the time you put a drain. Why do you put a drain?
So post-operatively, any bleeding might lead to respiratory depression, distress, sir. And
Yes.
so as a result
So
of this, in case of a
particularly
drain,
vascular gland,
yes, sir.
particularly vascular gland, there may be post-op bleeding, or there may be small ooze which might
Yes,
collect and cause compression. Okay, so that's why you put a drain. And
yes.
how do you close? Closer?
Sir, we have to close the deep fascia, sir. The deep fascia we close in interrupted sutures, and sir, we oppose the platysma using vicryl, sir, and then the skin can be given, sir, through with the help of monofilament or subcuticular suture or with staplers, sir, skin
Yeah.
staplers.
So what I suggest to other students is, Milinda answered very nicely, saying the salient steps. So when you describe the operative steps, try to divide the operation into different subheadings like incision, raising of skin flap, next is inside the deep cervical fascia, next is retraction of the strap muscles, then tackling of the pedicles, middle thyroid vein, suprathyroid vessels, inferior artery, inferior thyroid vein. Then look for the vascular supply to the isthmus. If present, ligate and divide. Then raising of the lobe from the bed. of trachea and esophagus. Cauterize the small vessels and lift the lobe, preserving the parathyroids. So try to describe for all operative steps. Try to describe it into different salient steps and describe what you do in the particular step. Dr. Maiti, any point you like to?
Dr. Milind, thank you for your nice discussion on the thyroidectomy. Regarding the dissection, one thing, when you are raising the flap,
Yes,
lower
sir.
flap downwards, and when you are taking care of the anterior jugular veins, and
Yes, sir.
you should look that there is a arch vein which connects both the anterior jugular vein inferiorly
sir.
at the suprasternal notch, and we should take care so that there is no injury to that arch vein, and sometimes for a better exposure that arch vein may have to be ligated.
Ligated, yes.
Regarding the strap muscles, the superficial strap muscle, as Professor Saha has mentioned, that is the sternohyoid and the superior belly of the omohyoid.
Omohyoid.
It is small swelling, no need of cutting those muscles. But if it is a very big swelling, sometimes you have to divide the strap muscle. Where you will divide? At the lower part of the muscle or the upper part? If you have to divide it.
Sir, lower part of the muscle, sir.
Now, if you divide the lower part, then the muscle nerve supply will be disturbed, because
Okay.
the nerve supply is from the lower part of the
From the
muscle.
lower part, yes.
So you try to divide a little at the upper part so that the major portion of the nerve supply remain intact. And if it is for a big swelling, the sternothyroid, as it is very much stretched on the gland, most of the time you may not divide the superficial strap muscle, but sternothyroid have to be divided for the better exposure. And regarding the thyroid vessels, you have rightly mentioned that the middle thyroid vein is to be tackled first, but middle thyroid vein, if you go on searching much and much, you may fail because it is not present in all the cases. It is present in around probably 20 to 30% of cases. If I am wrong, Professor Saha may correct it. As it is not present in all the cases, in only a few percent of cases, middle thyroid vein is present, and inferior thyroid vein, as it is at the lower pole of the gland, and if it comes fast in the dissection, as the veins are friable much more than the arteries, so you may tackle the inferior thyroid vein before you tackle the superior thyroid pedicle. When you are tackling the superior thyroid pedicle, for the malignant cases, sometimes you have to remain little away from the gland tip, but for the benign diseases, if you even take a bit of gland tissue, then your external laryngeal nerve will be at a safe side. So sometimes remaining close to the gland may go little on the gland, apex of the gland, so that the external laryngeal nerve will be protected. Particularly regarding the recurrent laryngeal nerve on the right side.
Yes, sir.
Often the recurrent laryngeal nerve, instead of being recurrent following the groove between the trachea and esophagus, that may cross transversely. If it happens, then the injury to the transverse recurrent nerve is much more. So take care of that anomaly. To identify the recurrent laryngeal nerve, we have mentioned the points, but another important point you may remember, sometimes that may be helpful, that is the inferior thyroid cartilage nodule, inferior horn of the thyroid cartilage. The
Yes,
recurrent laryngeal nerve most of the time remain at the upper part. If you dissect at the upper part or little more than the middle upper part, then you may find the recurrent laryngeal nerve is traversing behind the inferior horn of the thyroid cartilage, and then you can come down to follow the nerve below. Thank you. This thing I wanted to. Another thing you must remember, we should remember that when we are doing the hemithyroidectomy, because today we have the discussion on hemi and total, during hemithyroidectomy, how much isthmus you have to remove. So in your earlier part, the teaching was that hemithyroidectomy means you have to remove the isthmus and a slice of the contralateral thyroid lobe.
Yes,
But nowadays, the hemithyroidectomy is also taken as when you dissect the thyroid through the middle of the isthmus, because the ligating the isthmus is easier than to tackle a slice of the thyroid lobe on the other side. Because if you make a slice on the opposite thyroid lobe, on that side, the controlling the bleeding may be little more hazardous, more difficult. But when you are ligating the isthmus of the thyroid, remember, in addition to the arteria thyroidea ema, you may have to put an additional ligature at the upper border of the isthmus. The
Yes, sir.
superior thyroid artery on two sides communicate with each other by a branch which traverses along the upper border of the thyroid. In many of the cases, you may find a vessel traversing at the upper border. To have a good hemostasis, you may give an additional ligature, particularly at the upper pole of the, or at the upper border of the isthmus, so that
Yes,
there is no bleeding from the communicating branch between the superior thyroid vessels. Thank you very much.
Yeah. In fact, now the term hemithyroidectomy is also not used. It's not a complete lobectomy. Complete lobectomy means lobe plus the isthmus.
plus this.
And Dr. Maiti has mentioned about a nerve which is traversing in the upper part of the neck transversely. What is that called as? When it is not coming in the loop around the subclavian or the aorta, it is entering into the larynx directly. What is that nerve called as? The nerve which is coming in the groove is a recurrent laryngeal nerve.
Recurrent laryngeal nerve, yes, sir.
And nerve which is going directly is known
Sir, you muted, sir.
as recurrent laryngeal nerve.
Non-recurrent. Okay, sir.
Okay. Called as non-recurrent laryngeal nerve.
Non-recurrent.
And it's often associated with some
Sir,
vascular
situs
abnormalities. Yes, vascular abnormalities.
inverse
Okay.
vascular abnormality, yes, sir.
And
Okay. We discussed something about the post-op complication.
another
Yes.
controversy we must discuss, that is in a thyroidectomy, whether you will look for dissection of the recurrent laryngeal nerve, whether you will try to identify the recurrent laryngeal nerve in all cases or not. So that controversy is still there. Many surgeons prefer to identify the recurrent laryngeal nerve in all the cases of their thyroidectomy, but some surgeons prefer not to dissect the recurrent laryngeal nerve, not to see. They should stay away from the recurrent laryngeal nerve, particularly in which is possible in benign diseases. If you keep the fossa overlying the recurrent laryngeal nerve intact in benign diseases, remaining very close to the thyroid gland, and if you ligate the inferior thyroid vessels very close to the branches, as Professor Sahaj mentioned, if you ligate the inferior thyroid arterial branches very close to the surface of the thyroid gland, the recurrent laryngeal nerve will remain protected. The dissection or identification of the recurrent laryngeal nerve may not be needed, and you can push the fossal tissue behind after ligating the branches of the inferior thyroid arteries. Dr. Saha, your comment regarding this?
Yeah, but I think in the exam, if any operative steps, it's safe to say that I will identify the recurrent laryngeal nerve, try to find the recurrent laryngeal nerve, and the examiner asks is a different question. But first answer should be it is necessary to identify the recurrent laryngeal nerve. But sometimes it is difficult, and as you said, if you go into the same plane, preserving the fascia, you may
Yes.
not look for recurrent laryngeal nerve.
So there
But
is a term
first answer
probably
should be,
extrafascial or intrafascial thyroid.
Yeah.
The term is
Yeah,
there probably.
but first answer they will try to find the recurrent laryngeal nerve.
Yes.
Milind, you have done total thyroidectomy, and what are the complications of major complication, immediate? I'm not talking of late complication like sclerotrophy. So, what are the immediate complications following thyroidectomy?
Sir, immediate complications, sir, first of all would be hemorrhage. So
Yes.
second would be injury to the recurrent laryngeal nerve.
Yes.
Third would be, sir, a collection or a seroma formation, sir. And so fourth would be any iatrogenic injury to the trachea or the underlying structures, sir.
And some more.
Uh,
We're not talking of parathyroid,
Sir, injury, sir, hypocalcemia, sir.
hypercalcemia, and injury to the external laryngeal nerve causing
Sir, sir,
What is the effect of injury to the external laryngeal nerve? This is particularly annoying for singers.
The hoarseness of voice, sir.
No, portion of the voice is by
Sir, pitch. There's a change in the pitch of the voice, sir. There is
difficulty in making
lowering of the pitch of the voice.
high intonation voice,
Yes.
which is required for the singers. Okay, so patient has recovered well. In the table, patient was fine. In the evening round, you find the patient in severe respiratory distress. What are the steps you follow? In the evening round, you find patients having severe respiratory distress.
So,
So what's in your mind and how do you proceed?
sir, so we would like to, so I would like to, so first of all, see the vitals of the patient, sir, and this would include the blood pressure of the patient, the pulse rate, and also the oxygen saturation of the patient, sir. Uh, sir, if I have given a drain, then I would like to see what is the collection in the drain, and what is the nature and the amount of collection in the drain, sir.
Nothing is
Sir,
coming in the drain. Nothing is coming in the drain.
sir,
Zero.
I would like to examine the wound site, sir, and see
Yes.
if there is any bulging of the scar, if there is any active bleed, or if there is any soakage of the dressing material at the wound site, sir.
So you find the wound is bulging. The wound become tense and wound is bulging and patient having severe distress.
Sir, in this case, sir, I would suspect,
What is the likely cause in this situation?
sir, the likely cause would be can be a hemorrhage, sir.
Hemorrhage. And you find the wound is flat, there is no bulge, but patient is having severe stridor and respiratory distress.
So then it can be an injury to the recurrent laryngeal nerve, sir.
One or both?
Both, sir.
Both. One nerve injury may not cause respiratory distress.
Yes, sir.
So it may be the injury to the both recurrent laryngeal nerve. Okay.
Yes,
So
sir.
now you are tackling with a patient who has got a possibility of bleed and there is a underlying tension hematoma. What is the management?
So the immediate bedside management would be, sir, I would like to remove some of the sutures from the edge of the wound, and I would like to drain the collection that is there, if any. I would like to drain the collection that is there. And sir,
So
I
you
would like
do a mini surgery in the ward itself.
no, sir, I would just like to open the wound and
So
allow the drainage.
don't try to drain the hematoma in the ward. Your
Okay, sir.
job is to just take few stitches out so that the wound is decompressed
Decompose.
and
Okay.
and take
And take the
measures to
patient,
take the
sir,
patient to the
immediately for
yes.
take the
What do you
patient
do?
immediately for re-exploration, sir.
What do you do in the theater?
Uh, Sir, in the theater, sir, we expose the bed of the thyroid again, sir, and we look for
Anesthesia. Anesthesia.
yeah,
It should be again under general anesthesia
general anesthesia. Yes, sir.
because you don't know where it is bleeding.
Yes, sir.
It might be bleeding in the upper pole or some uh, unnamed vessels. So you need a thorough exploration.
Yes, sir.
Under local anesthesia, it will be difficult to do the exploration
General anesthesia.
because you are not sure about the site of bleed.
Yes, sir.
Okay, so a thorough exploration requires the patient to be under general anesthesia.
General anesthesia.
Then,
So then,
you-
I yes, sir. Hello.
yes, yes.
Yes, sir.
Where
So
do you
then I
look
would.
for?
So we sequentially go through all the sites
Yes.
of the one by one, and we keep on securing. If we see any bleeder, we go in the same order in which we had gone in the original surgery, and we look at each of the sites and we try to secure any bleeding point if there is.
Fine. This scenario was not bleed. It is likely to be a respiratory distress due to bilateral recurrent pulse. And patient is having stridor in the bedside. What do you do?
Sir, this stridor or sir, this can be a temporary so this can be due to a temporary injury to the recurrent laryngeal nerve, such as a pull or a traction, or this can be permanent, sir. In that case, initially I would like to give the patient oxygen and see how the patient is responding. I would like to see the positions of the vocal cords of the patient, sir.
What do you expect? Patient who is having stridor What do you
Yes, sir.
expect the vocal cord to be?
Uh, Sir, the patient, the position, it might be in, sir, a cadaveric position, sir.
Will it cause stridor?
Uh, Sir,
Respiration stridor will happen when the vocal cord in paramedian position.
paramedian, okay, sir. Paramedian
Okay.
position. Yes, sir.
So whatever is it temporary or permanent, when the patient is having respiratory distress and vocal cord in paramedian position, you have
Yes,
to
sir.
take some immediate measures. What is the measure?
Sir, I would like to then intubate the patient, sir, and
In a very difficult task. An obese cannot do intubation when the vocal cord is in paramedian position. Okay.
yes, sir.
You
So,
need a, yes.
so then I would like to go for a tracheostomy, sir.
Okay.
Yes,
So if you have anesthetists around,
yes.
you can try to intubate the patient,
Okay, sir.
or else you need to do a
Tracheostomy, sir.
what is the subsequent management?
Uh,
What is the subsequent management? You have done tracheostomy,
sir.
patient is breathing, fine, no distress.
Sir,
Subsequent
initially,
management depend on what?
sir, whether there is return of the vocal cord activity or not, sir.
Yes. So subsequent management depend on whether this is a transient injury,
Or a
transient
permanent.
palsy of the nerve, or permanent palsy.
Yes, sir.
If it is transient palsy, by 2 to 3 weeks or 4 weeks time, this recovers.
Yes, sir.
So do a review ENT examination.
Yes, sir.
Find the vocal cords are moving now. It was probably a transient injury, so you can take the tracheostomy tube out.
Yes, sir.
So if it's a permanent injury and vocal cords are not moving, what measure you can take?
Uh,
There are some
sir, I'm not
ENT
sure.
procedures
Okay, sir.
which can open up the vocal cord.
Sir, the posterior,
Thyroidectomy.
arytenoid, yes, sir.
Okay, so this can open up the vocal cord.
Yes,
But
sir.
in that case, the problem is the sensation is also gone. So patient has high chance of aspiration.
Aspiration.
Okay. This patient probably has some parathyroid gland injury. How do you diagnose in the post-op period patient is developing hypocalcemia?
Sir, we do it, we can do it clinically, sir, and with the help of investigation, sir. Clinically, sir, if the patient is developing, sir, the
What is the
patient,
earliest symptom? What is the earliest symptom of parathyroid insufficiency?
sir, perioral numbness and tingling,
Perioral tingling and numbness
numbness,
is
yes,
the
sir.
earliest symptom of hypocalcemia. How fast this hypocalcemia develop in the post-op period? How fast these hypocalcemic symptom may develop?
Sir, there is a component of, sir, temporary hypocalcemia, even there might be, sir.
No, whatever, temporary or permanent, that is not the problem.
Sir,
So if the patient
not
was
sure, sir.
normocalcemic,
Yes, sir.
one of the parameter in the POP is to do a calcium estimation also. So
Yes, sir.
if the patient was normocalcemic, it takes about 24 to 72 hours to develop the symptoms of hypercalcemia.
Yes, sir.
If the patient was borderline hypercalcemic in the pre-op period, this patient can develop symptoms within even 6 to 12 hours.
Okay, sir.
So these are symptoms. What other symptoms may come up? If you are not treating the patient with this earlier symptom, what other symptoms may come up?
Uh, Sir,
One is tingling and numbness around the
um,
mouth. Then,
okay, sir.
then what happens? In the limbs,
So there is, sir, sir,
only tingling numbness in the
no,
digits
sir.
and toes.
Yes, sir. Digits.
And that ends at what? That ends at carpopedal spasm.
Carpopetal spasm.
Okay,
Yes, sir.
it can lead to a acute hand.
Yes, sir.
So patient has not gone to this severe phase. You are trying to diagnose early. What the signs you can elicit for hypocalcemia?
So Vostex sign, sir.
What is that?
Uh, so we apply
Where do
a
you
blood.
tap? Where do you tap?
So we tap at the angle of the mandible, sir.
Angle of mandible, no. You tap in front of the tragus.
Okay, sir.
You tap in front of the tragus, and what is going to happen?
So there'll be contraction of the twitching of the facial muscles on that side, sir.
There will be twitching at the angle of the mouth.
Angle of the mouth. Okay.
So you tap in front of the tragus, there will be twitching at the angle of the mouth. So that indicates the muscle is in tetany.
Yes, sir.
And then any other test?
So Tuzo's test, sir. Tuzo's sign.
Glabellar tap. What is that? You tap in the forehead.
Okay, sir.
There will be twitching of the orbiculis oculi muscle.
Yes, sir.
Glabellar tap. And then you do the blood pressure cuff
Yes, sir.
to
Tuzo's sign, sir.
sustain.
We inflate the
And
cuff,
then,
sir, and then there'll be spasm of the hands and the
yes.
fingers.
Okay. Then how do you manage? Patient has got fluid symptoms, and you demonstrate that patient has got severe hypocalcemia. How do you manage?
Sir, in the initial phase, sir, we would like to send a serum calcium, sir, to see the
Yes.
level of the hypocalcemia, sir.
Yeah.
Then, depending on, sir, how much the hypocalcemia is, sir, we would like to either go
Patient
for
developing symptoms in immediate posterior period is having severe hypocalcemia. So what measure you take? What do you give?
sir, we'll give sir. So we'll supplement calcium, sir. Calcium carbonate we'll give.
Orally?
No, sir, injection, sir.
Yes.
So 10%, 10 ml of 10% over 10 minutes, sir.
Yes. Calcium gluconate.
Calcium
So
gluconate.
you give a shot. And the patient has got severe hypocalcemia, may not be relieved by single shot of calcium gluconate. In
Yes,
that case, we might need to give a calcium gluconate infusion
infusion.
and then start the patient on oral calcium supplement.
Calcium,
At
sir.
the same
And
time.
vitamin D supplements.
Yeah. Okay.
Yes,
So
sir.
again, if it is a transient hypoparathyroidism, you keep the patient on calcium supplement and vitamin D. And then
Yes, sir.
keep on calcium.
Yes, sir.
With the transient hyperthyroidism, patient may be tailed off this calcium supplement.
Yes, sir.
Okay, that will
Yes, sir.
depend on the calcium estimation and tailoring the calcium supplement. Okay, what will be the delayed complications of total thyroidectomy?
Sir, delayed complications would be sir, wound infection, sir.
Complication is immediate complication.
Sir,
Scar related problem is a
scar
delay.
formation, sir. Flap necrosis, scar formation. Sir, then
And
hoarseness of voice, sir. Change in the quality of voice.
Total thyroidectomy lead to hypothyroidism. Okay,
Yes, sir.
or you need to give the
Supplement thyroid, sir.
thyroid supplement. Yes. Dr. Maiti?
Yes.
Yes.
Dr. Milind, first I want to know, Dr. Milind is working as a SR now?
No, sir.
No.
Final year PGT, sir.
Oh, final year PhD. I thought you have passed last year. So, regarding following thyroidectomy, another important step a surgeon should follow, always ask the anesthetist to check the position of the recurrent laryngeal nerve and document it in your bedded ticket that it is okay, it is moving perfectly, normally. and another
Vocal cord movement. Yes.
vocal cord movement.
After extubation.
Extubation, that must be noted. And also you yourself check the endotracheal tube, whether it is blood stain or not. If there is in a very difficult thyroid cases, there is even the chance of injury to the tracheal cartilages or the larynx. So in that case, the endotracheal tube may be blood stain. So that should be noted also. And cadaveric position you have rightly mentioned, and that occurs only in case of bilateral recurrent laryngeal nerve palsy. Now, in cadaveric position, the immediate postoperative period, there may not be any respiratory distress because of paralysis of both the vocal cord. The gap between the vocal cord is adequate for the normal respiratory function. But once the patient is in stress, when with exertion, only the respiratory distress will be observed. So that should be taken care of, that in cadaveric position, the respiratory distress usually occur when the patient is exerting, is in stress. And the role of steroid. You see, other than the hematoma formation, other than your recurrent laryngeal palsy, the infection and the traumatic edema may be one of the cause of narrowing of the larynx. So if you find that recurrent laryngeal nerve palsy is not there, if there is no hematoma, you should look or you should search whether, you should also take care whether it is edema or not. In that case, good antibiotics and the steroids, hydrocortisone, had some role. Okay, these things like what are the clinical features of hyperthyroidism? Just one for academic interest, I'm asking you. What are the features
and
of
the complications of
hyperparathyroidism? Hyperparathyroidism.
Yes. Oh, hyper.
So hyperparathyroidism, sir. Hyperthyroidism.
Hyperparathyroidism.
And we missed one thing, is a thyroid storm. If you are
Thyroid.
operating on a toxic goiter patient or not prepared, patient may go to thyroid storm or
Thyroid
thyroid
storm.
crisis. So what are there are classic mnemonic for symptoms of hyperparathyroidism?
Yes, for that I am just asking. That is not present in the postoperative patient, but that is a clinical condition. Sometimes the patient may present with hyperparathyroidism. A lot of things have been discussed by Professor Saha regarding the hypo in details. Regarding hyper, if you remember that slogan, it will be very easy for you to express what are the clinical features of hyperparathyroidism.
You
Sir,
know the mnemonic? Abdominal groans, cytic
groans,
and-
moans,
and renal
stones.
stones.
renal stones. Yes.
Okay, so that is the thing, and other thing.
Okay.
Okay.
Thank you, Dr. Maiti. You have a good. So operative steps, you should read about the indications for the surgery, the steps, and some post-op complications and their management.
And other points must also be mentioned about the parathyroid implant. So every time you have to take all the care so that at least you can preserve at least two parathyroid, or at least 1.5 of the other parathyroid. But if you are sure that you have removed all the parathyroid and your specimen, if you find the parathyroid, there is scope of implanting the parathyroid in any of the muscles in the neck.
Yeah. Auto transplantation.
Okay, auto transplantation.
Yes, sir.
Most of the time it may be destroyed, it may be lost because of avascularity. So you can have a chance to implant the parathyroid in the sternocleidomastoid muscle. Though theoretically it is also discussed that you can implant in the brachioradialis, in the polar muscles. But for the surgeon, it is very easier and convenient to do immediately to implant in the sternocleidomastoid.
Yes.
How is it done? What do you do with the gland itself?
So
you find the parathyroid, you have to
we place it, sir, in the fold of the sternocleidomastoid.
as such, or something needs to be done.
This
parathyroid has to be minced.
Oh yes, sir. We have minced it and
place this parathyroid gland, cut into pieces, mince it,
yes,
and then place it into the parathyroid in the sternocleidomastoid.
Why it is done, Milind? Why it is
Sir,
done? For
because
example,
because since the gland is removed, the blood supply has been lost, sir.
no,
So
why it
when
is
we
minced? Instead of placing the gland intact, why you minced it? Why you make it like keema?
so to ensure that it stays in position, sir.
No, the blood supply will be more ensured. If it
Yes,
is a solid one, is a big one, the
Yes, sir.
vascularity cannot reach at the interior
Yes,
of
sir.
the mass. But if you mince it, a small gland portion will
Yes,
be
sir.
adequate to get the nutrition, serum at least,
Yes,
and some oxygen
From the
through
stomach.
serum
Yes.
from the surrounding tissue. The same
Yeah.
thing is done for auto transplantation of spleen. When you
Yes,
are
sir.
doing the splenic transplant in the data momentum, always you have to make the spleen into small slices of less than half centimeter like that. So that will ensure the blood supply to the splenic tissue.
Okay, thank you, Milind. You
Thank
could
you, sir.
proceed. Malavika might have some connectivity issues.
Yes, sir.
Okay.
I'm still not able to reach her, sir. Probably she.
Yeah. Okay. Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir.